Welcome to the webinar. You have entered as an attendee in listen-only mode.
Welcome to our webinar, Humanizing Care, Providers and Payers Redefining Population Health Management with Social Determinants of Health. This is Dr. David Nace, Chief Medical Officer here at Innovaccer. I'll be moderating the call. But first, before we get started, I just want to give all the attendees some housekeeping rules. We'll be taking questions at the end, so please use your chat box, the GoToWebinar chat box to your right, and please enter your questions throughout the webinar. Periodically, we will be doing a poll, and we may answer some of your questions during those polls. So it's really helpful to get those timely questions into the chat box as soon as you think of them. So with that, well, let me get started. And I first would like to introduce our speakers, our panelists for today. So let me introduce Dr. Andrew Renda. Dr. Renda is an Associate Vice President of Population Health at Humana Health. He's presently leading 4 population health work streams at Humana, and in particular, population health insights, social determinants of health strategy, along with data and analytics as it pertains to that. And he's also had a long history of supporting Humana's bold goal of increasing community health by 20% by 2020. Dr. Renda, welcome.
David, thank you very much for having me.
Good to have you here. And I'd also like to introduce Dr. David Nash, who's the founding Dean Emeritus at Jefferson College of Population Health. Dr. Nash has been at Jefferson for quite some time and is internationally renowned as a healthcare thought leader, particularly in the population health management arena. He's also the Dr. Raymond and Doris N. Grandin Professor of Health Policy at Jefferson University, and has been on the board of directors for the past 10 years at Humana and recently completed his term there. So this is a nice bringing together around some of the work that Humana has done from 2 sides. Welcome, Dr. Nash.
Thanks, great to be here.
Great. So with that, let's get started. So David, you know, you've been teaching all of us in this country about the role of population health and population health management techniques for your whole career. And if I think back to just 10 years ago, if not more recently, you know, when patients had issues like congestive heart failure or other ambulatory sensitive conditions, they would go to the emergency room and the physicians who saw them really had little insights into the major factors impacting their health while they were there. Can you speak a little bit about where we're at that juncture in population health management?
Wow, what a great kickoff question, and it's just so much fun to be here with Dr. Renda and with you. Yeah, so 10 years ago, gee, that's when we opened our school. So I spent the first 2 years on campus answering the question every single day, what's population health? Aren't you opening a school of public health? So I just love the fact that you picked a decade ago. So we believe that population health, and we'd like to give credit to people like David Kindig and others who were writing about these issues almost 20 years ago now. We believe that population health basically says, hey, it's not about delivering medical care services or healthcare services. It's all about what actually makes us healthy. And population health management takes that one step further and says, not only are we interested in what makes us healthy, but how do we apply that learning to the population at hand? And we'll get into the details. But to try to answer your impossible question, David Nace, you know, 10 years ago, I think most folks, including us, were just trying to understand what contributed to making people healthy. And we came to the sad conclusion that it was not the delivery of healthcare services, that it turned out to be everything but that. And later in our time together this afternoon, we'll get into some of those factors. But having been inside a major delivery system here at Jefferson for the last 30 years, Imagine how we all felt a decade ago when it became pretty clear that it wasn't about us. Imagine that it was about everything but the delivery system. So that's where we are today, is recognizing that the delivery system is certainly an important part of improving health, but 80% of the story has nothing to do with what we do at the bedside. And we'll get into the details shortly.
Absolutely. And you often use this mantra of no outcome, no income for the future.
Yes. Yes. Well, we like to think that at the nation's first population health, and folks, of course, appreciate there are more than a dozen such schools nationwide now, and scores of departments of population health in American medical schools, both osteopathic and allopathic. But we coined this phrase almost a decade ago now, trying to explain to people, and I think it's very applicable today as it was 10 years ago. No outcome, no income, which is a little bit snarky, but basically we believe it's another way to think about value-based payment. It's another way to think about going upstream to shut the faucet rather than constantly mopping up the floor. It means maybe we should not build another cath lab or another bariatric surgery center, but rather we should start thinking about what contributes to health. And the way we're going to get paid, no outcome, no income, might help us to focus on what delivers health to a majority of the population.
No, and I know that certainly here at Innovaccer, some of our clients, such as the Mercy Health Network with Common Spirit, we've actually been able to show that they've been able to increase their income $5 million over 2 years by a shared savings program by just reducing readmission rates and ED visits. And in order to do that, you have to increase their health, which means looking at the community and increase their role of primary care.
And this is that's great information from one of your leading clients. And I'd like to take this and multiply it by, exponentially for the rest of the country.
So Dr. Renda, there's a new way of thinking here about risk and really being an insurer like Humana has been. You think about risk, right? How do you manage it? And now there's new ways to pay for care. Can you say a little bit about the evolution that we're seeing in the market that allows us to address this issue of no outcome, no income?
Sure, absolutely. And first, I'd really like to just echo what Dr. Nash just said. I mean, to me, this whole where we're going with population health is a back to the future sort of thing. So going back to Jeffrey Rose back in 1985, one of the fathers of population health, he talked about two ways to improve health of populations. One was a high risk approach, trying to help those that already have disease, complex, chronic, et cetera. And then the other approach is a population health approach. And that's the idea of shifting the distribution of risk for an entire population. So rather than going with somebody who's already had a heart attack and prevent the next one, let's take everybody in a population and improve their cholesterol or their blood pressure by 5 points. And so taking that approach and putting it into payment models, now with these alternative payment models, it's all about quality. It's all about value-based outcomes. And so that's really where we're moving, is not just fee for service, paying for medical services, but it's about paying for outcomes, improving the health of individuals and populations.
That brings us to the topic of today. Like, what is the role of social determinants of health, SDOH, and how can we start thinking about building social vulnerability assessment into our population health management techniques? How do we bridge the gap between clinical and social needs? This seems to be a really important issue, right, that we need to address. Gentlemen?
Well, this is a great slide that helps to highlight actually connecting the dots, right, from doctors to the skilled nursing, long-term care, pharmacy. In a typical delivery system like Jefferson, just as an example, 16 hospitals, we have patients in scores of zip codes who go to all kinds of facilities not directly connected to us, who go to pharmacies all over our region, and without a common platform, it's awfully hard to know who's going where for what, and how do we close this loop that you've portrayed here. I mean, I think that's part of population health management, is connecting the dots literally as you've got them portrayed. And we're learning just how hard that is. In a closed system where you might even have the providers and payers linked, so-called payviders, you know, in a closed system, it's a lot easier to connect these dots. In the typical integrated delivery system, this is a major challenge. So bridging this gap between the clinical and social needs, even collecting the information from patients on the social determinants, where exactly does that go? Who gets to see it? How do we get actionable information from the data on social determinants? These are all questions we have to consider today.
And these are great questions. We're going to get to Dr. Renda telling us about a case study, what they've done at HUMANA'S.
Well, if I could just add briefly to what Dr. Nash said, I mean, I think the way we bridge the gap is to elevate social determinants to being considered as clinical gaps in care. So whether it's a physician or it's a care manager that's addressing a chronic condition like diabetes, alongside asking about medication adherence and screenings, they're also asking, do you have food in your refrigerator? Do you have access to transportation? Different things like that. We need to elevate them to treat them as the gaps in care that they actually are. And one other way that we do that is by codifying social risk. It's defining our terms. So I think sometimes there's confusion about what social determinants are. Social determinants are the social, economic, environmental things that impact the health of a population. Health-related social needs are those social needs that impact an individual's health. And so I think defining our terms, agreeing on common definitions, and then cascading from there, we can have validated screeners and things like that, so that we all know what we're talking about. I think that's absolutely fundamental to elevating social determinants as clinical gaps.
Great perspective, and we're going to get into that for a second. But first, let's turn to our audience and see what they're doing around thinking about social determinants of health as a component of their healthcare strategy. So audience, please, we're going to bring this poll up in just a second, and then we're going to ask you to just pick one of the answers here. To what degree is your organization leverage social determinants of health as a significant component of your healthcare strategy? One is, well, we don't believe it's our role. Two is, we've started to explore the idea. And third is, we're testing out some pilots or ideas, or we're actually fully engaged. So in the meantime, Dr. Nash, where do you think the landscape is? What's your guess on what our poll is going to show here?
Boy, yeah, if I had to handicap this, I'd say we're probably somewhere between choice 2 and 3. Most organizations are just now beginning to explore this idea and taking some baby steps, putting a toe in the water, whatever analogy you like. But back to Dr. Renda's comment, I think many practitioners find this very difficult. I mean, most of us certainly weren't trained this way, especially guys as old as me. Asking patients questions about what's in their refrigerator, did they have adequate transportation. I think for primary care doctors of a certain age, this is all radical new stuff. So I would say most organizations are just beginning to get their arms around this. It certainly will be stimulated by changes in reimbursement, and we all would agree, I think, it's not going nearly as fast as we would like it to be.
And Andrew, is this sort of reflective of what you see in your networks?
Yes, absolutely. I think it's all across the spectrum. I think there aren't many that say they don't believe in social determinants, but I think it's exactly like Dr. Nash said. I think between 2 and 3, people are beginning to explore the idea. They're testing some things, but there's not too many that are all in yet. And part of it is exactly what Dr. Nash said. I think a lot of physicians weren't trained to address these things. They don't have the infrastructure, the analytics, the platforms. They don't know where to send a patient if they say they're food insecure, for example. And so I think that's something we need to address is sort of the education piece, the technology piece, and the intervention piece. Those are 3 things that we need to do if we're really going to move people to be fully engaged with addressing social determinants.
Awesome. So let's take a look and see what the survey says. Well, this is interesting. I think you're right. Nobody doesn't believe in it, but geez, it's spread all over. Does this resonate with what you thought the results would be, gentlemen?
Well, I'm surprised when 30% almost are fully engaged. Well, that's pretty awesome. Fantastic. I sure would like to see some results and some analysis of the outcomes about which they are fully engaged. That's exciting.
Andrew?
Absolutely, fully agree. I mean, I think Humana certainly is all in on this. Glad to see that others are as well, but it's true. All in means you're committed to addressing these things, but the proof is in the pudding. We need to demonstrate a clinical case for doing these things, meaning we're generating clinical outcomes, and there needs to be a business case for it as well. If it's going to be sustainable, then there needs to be a business case. We need to show that by addressing social determinants that we're keeping people out of the hospital, out of the ER, we're lowering total cost of care for patients. And that proof doesn't quite exist yet. I believe in it. Sounds like many people believe in it, but we really need those proof points.
This is reassuring, that's for sure.
It's exciting, actually, and we might
Yeah.
see it shortly. So, Andrew, you and I were talking the other day about how this is sort of reflective of Maslow's pyramid, right? If you don't have safety, if you don't have shelter, if you don't have food, right, then you can't do other things like address your medication compliance, address your exercise, address, et cetera, that kind of helps you in chronic disease. Can you say a little bit about kind of the strategy you've thought about for whole person care?
Absolutely. So this is the Maslow's construct that as Humana views it. So talking about sort of the base level that's required to generate a population health strategy that's effective is that we need sustainable, strategic community and physician partnerships. And so we all know health is local, and so you can't do it from an ivory tower. You can't do it purely from big data. You have to have boots on the ground in communities, and you have to meet with community stakeholders, for-profits, nonprofits, faith-based, governmental, to really understand the issues that are happening in a community. You need to agree upon things that you're going to address, be they chronic conditions or social determinants. All that is part and parcel. It's fundamental to what you're going to do. Once that happens, then you can go up a level and say, okay, we are going to be upstreamist. We're going to go upstream and deal with the social determinants of health and the health-related social needs. Social determinants are on the population side, health-related social needs on the individual side, but we need to elevate them as clinical gaps in care. We need to address them together, partnering with community organizations. Once we begin to do that, we get some of those proof points. We take those proof points and we go to Washington, D.C., and we work on policy change. Some of that policy change can be around things like food stamps. Other times, policy change can be about, from an insurance perspective, it's what we're allowed to cover from a supplemental benefit standpoint. And we can talk about that a little bit later, but up until very recently, we weren't allowed to cover social determinants on supplemental benefits. And so we get up there, and then if you start to address it at an institutional and a fundamental level, then eventually you're going to improve health-related quality of life, you're going to improve clinical outcomes, and you're going to lower total cost of care.
Yeah, we've known for some time that, only 20% of outcomes are really driven by clinical interventions, maybe including genomics, but there's this other 80%. And the whole issue about access to food and loneliness, but you just mentioned a really interesting term, upstreamist. David, what do you think of that?
Yes, wow. So I want to thank Dr. Renda for adding to my vocabulary and everybody else's today. I just recently heard about the payer provider coming together as a payvider. So I think I want to become an upstreamist working at a payvider.
Andrew, thank you for the terminology. That's great. So, David, with this slide, why has this been so challenging to sort of bring the traditional clinical teams that are trained in the universities like Jefferson together with the communities?
Well, there's plenty of blame to go around, not just here, but everywhere. The biopsychosocial model in medical schools, even at great places that talked all about the impact of where you lived on health, still connecting the dots is still very difficult to do. Even understanding what are the resources available. So for example, when you find that somebody is got social isolation and loneliness. And I know from my 10 years of work with Humana that we know that loneliness in the elderly leads to depression, which leads to dementia, which leads to great expense and heartache for the family. So given those connected dots, then how do we go upstream to tackle the loneliness? Well, that's not easy. That means we have to have community centers, transportation, people who understand how to get folks from point A to point B. So connecting all these dots is still a lot of hard work on the ground, and making it economically viable and incenting us to connect the dots. I think that's where we've got to go. So I'm excited about some of the new payment systems. I'm particularly excited about things like the oncology care model, like CPC Plus, and like the new agreement between Blue Cross Blue Shield in Minnesota and primary care practices. I think you're going to see more collaboration between payers and providers to help create some of these more exciting models of how we're going to deliver care in the future.
So let's talk about these factors in just a second. But in the meantime, let's take another poll of our audience and say, okay, people now recognize, right, that adding social determinant of health management into their population health program is helpful, but not everybody's doing it, right? We only have like 30% that are robustly doing it. So what are the barriers? So let's go ahead and pull this poll up. And, you know, David, I was just thinking about our last comment with the factors that are non-traditional clinical. You've often said that the two major indicators of someone's outcome may be their zip code and their credit score. Wow.
Right.
Yeah.
Well, it'll be fun to see what the audience says to this question. I think by now most folks understand that in our country, geography is destiny as it relates to health. And it's multifactorial, but probably the biggest factor is, your zip code as a proxy for your income. And if you look at Philadelphia, it's exasperating for us for sure, but we, in the nation's top 10 cities by population, we're number 5 or 6, depending on whether Phoenix or Houston are counting. But we have the largest disparity in lifespan based on geography. Meaning, if you're in a zip code close to where I'm sitting, Society Hills, Center City, Philadelphia, your average life expectancy is 88 years. If you get in a taxi with me and we go 6 miles north up Broad Street, life expectancy in that zip code is 66 years or 68 years. So we have an unbelievable disparity in not just health, but lifespan. And when you drill deeper and deeper into what are the attributes that cause this, it's all about health, wealth, education or lack thereof, access to care, and then all the environmental factors, and particularly the diseases of despair, drug abuse, depression, alcohol, and suicide. So it's a scary picture.
Yeah, and it's funny, I'm looking at some of the questions that are pouring in, and I got a great one for Andrew related to that point, which is, as we start to do more and more research, like you're doing at Humana, Andrew, like what if the research showed that the social determination of health efforts to improve health overall worked, but they ended up costing more? How would you view that as a payer?
Well, they're always going to cost money up front. And I think the challenge for us and for everyone really is that sort of the further upstream you go in terms of where you're intervening, the longer it sometimes takes to see that return on investment. And so I don't necessarily agree that things are going to cost us more in the long run, but I think we have to open our aperture a little bit, and we have to get beyond the sort of traditional mindset of we need a 1-year ROI on any intervention that we do. And so sometimes it may take 3 years or 5 years or longer. And so we have to think about, certainly in insurance models, in our Medicare membership, we might keep a member 8 or 9 or 10 years, and that gives us a longer runway to intervene. It's a little bit more challenging in Medicaid populations and commercially insured members where the churn is a little bit quicker. But fundamentally, I think we have to be willing to invest up front and understand that the payoff may come further down the road than we're used to or are currently comfortable with.
That makes good sense. Well, let's turn and see what the results of our audience are in terms of where they see the barriers to integrating social determination of health. Interesting results. Interesting results. Andrew, what do you make of this?
Yeah, I'm frankly not surprised. I think these are all barriers. They're all surmountable barriers, though. I mean, certainly there are current budget constraints, but again, as we get into value-based reimbursement models, it's going to be in everyone's interest to invest in addressing social determinants of health. I think it's true that there are, in some cases, a lack of insights, but that again emphasizes the importance of research, insights generation, the importance of data and advanced analytics. And like I've mentioned before, the standardization of assessments, again, we have to codify social determinants, period. We need to define our terms, we need to be clear on definitions, we need to have validated screeners that we're using, and we need to have clear protocols for connecting people to the resources they need.
Yeah, David, Nace, I want to emphasize something Andrew just said. I think that lack of standardized assessments to identify the social needs, it's a little cumbersome here, but I think the issue is better measures of what exactly are the social determinants that are in play and how can we change them and modify them. Those measures are going to be very valuable because that will help us to tackle them, and we'll be calling an apple across the spectrum. So the lack of standards is really important, and big organizations like Epic and Humana working together, our college, we're trying to create some standards to help measure the social determinants. That is not easy to do, but once we have some agreement, then we'll be able to actually have a conversation with some real evidence behind it. But I think for today, August 2019, the budget constraints are probably the biggest marketplace challenge.
No, absolutely. And what was interesting to your point previously is that most people, 6% said no barrier, and they're already doing this. And people didn't see resources as a lack of resources in the communities being the issue. It's needing some standardized approach, some way to bring insights right into the, I'm assuming into the, the physician, the care manager about what to do, right? About how to address these issues. And then the budget. The issues around, are we going to get paid for this, or that's an internal issue for health systems as well as a payer. I mean, it's everybody's got to be involved with trying to figure out the longer term view, to Andrew's point. So really, really good stuff and great insights from our attendees. So let's turn to a case study and talk about Humana. Andrew, I know you've taken the lead here at Humana in addressing the BOLD goal, and David was on the board during this whole process. Andrew, can you say a little bit about your BOLD goal initiative and what this is all about?
Sure, absolutely. So in 2015, our CEO, Bruce Broussard, declared our BOLD goal, which was to improve the health of the communities we serve by 20% by 2020. And as we near 2020, we realized the work is not complete, and so now it's 2020 and beyond. And so that was really a bold goal, the idea of improving health for an entire community or an entire population by 20%. And so he sort of turned to our team and said, okay, figure out how to do that. and the first step in that really was to figure out, what do we mean by 20% healthier? What metric are we going to use for that? And so for us, it was about health-related quality of life. And we evaluated a number of different measurements and tools for that. And we settled on the CDC Healthy Days tool. And we really like that a lot because it's a very simple, easy to administer survey. It's just a couple of questions, but it gives equal weight to physical health and to mental health. And so it just asks, how many days in the last 30 have you been either physically unhealthy or mentally unhealthy? And so that right there is a self-report measure by design. It gives us a lot of information about how someone perceives their own health. And so everything that we've done in the last 3 or 4 years has really cascaded from that. And so we, if you go back a slide just for a sec, we've used that Healthy Days measure in a number of different ways. First and foremost, it's been a surveillance tool for us. And so we've been able to survey our populations across different lines of business and in different communities to understand a baseline of unhealthy days in those populations. And then we've trended year over year to see if our interventions and our overall strategy is making a difference. We've also been able to use the Healthy Days tool in our interventions themselves. And so anytime we do an intervention, whether it's to address diabetes or whether it's to address food insecurity, we look for outcomes in 3 categories: health-related quality of life, clinical outcomes, and utilization and cost. And so in that scenario, Healthy Days becomes that leading indicator. People's perception of their health often changes before their actual clinical health does. And the third way we've used this has been highly relevant as we've expanded our Medicaid population. As we get these new members in that have unique health challenges, we don't know often a lot about their health status. And so we can proactively call them, ask them the Healthy Day questions, and we've decided that anyone who screens over 20 unhealthy days, we will immediately warn transfer or call back with a health navigator, and then figure out whether they need to be triaged to a community resource, to a clinical resource, or help just navigating their health plan benefits. And so it's been a really great tool for us, and everything else that we've done is cascaded from that.
Yeah, what I've been really impressed by is the way you've shown here that for unhealthy days, it's the drivers really been issues around things like food insecurity, loneliness, and not really their diagnostic chronic condition or line of business. So it's fascinating.
Yeah, it's been really interesting for us. It's really generated a lot of insights and helped us focus our work. So you can see different lines of business report different number of unhealthy days, different chronic conditions report different number. Social determinants actually are the biggest drivers of unhealthy days or health-related quality of life for our members. And what's been really interesting is to figure out where these populations overlap. So if you have a Medicaid member who has depression and is also food insecure, you suddenly see an exponential increase in unhealthy days or a worsening of their health-related quality of life. And those are the people that really need intervention. And so these insights have really driven our focus.
So if we look at
Hey, David, I would just jump in, go back another second there. I would add to what Andrew was saying, and we know from the bold goal that when you tackle the social determinants, there's savings on a per member per month basis. So I want our listeners to appreciate that the payers have the economic incentives aligned appropriately to tackle the social determinants. Let me put it bluntly. There's a margin to be made by improving the social determinants. These people, when they report fewer days of loneliness or fewer days and a lower scale of depression, they reduce utilization. So this is really great data that's just now being assembled in places like Humana and elsewhere.
And I think the drivers that have been shown around this with the work at Humana has been that if you have food insecurity, right, you have to choose between food and medical care. And obviously, from a Maslow perspective, that drives decisions, and the same with being isolated. Andrew?
Yeah, that's absolutely true. And just to back up for a second, I mean, one of the challenges we found is that we know social determinants of health impact health and health outcomes. The challenge that we had is that, you know, there are 60 some odd social determinants of health if you use the Robert Wood Johnson Foundation definitions, which we do. And so we did a really interesting research study, which we published in Population Health Management, and we looked at combining the Robert Wood Johnson data on social determinants, their county health ranking report, with Humana's Healthy Days data, and we looked at if you could improve a single social determinant from the 25th percentile to the 75th percentile relative to other counties, what would be the improvement in health-related quality of life? And when we did that analysis, we found that the top 2 opportunities, or the biggest drivers of unhealthy days, were number 1, loneliness or social isolation, and number 2 is food insecurity. And so since then, it's really helped us narrow down our focus. We've built analytic and intervention pipelines around both of these things. And, while we've been doing that, we've looked at other, external research, and you can see it right here. If you are food insecure, you are more likely to be diabetic. You're more likely to have heart failure. You have, as Dr. Nash pointed out, higher utilization, higher total cost of care. And the same exact thing is true for loneliness, particularly in seniors. Almost half of seniors are lonely, and they're both indirect and direct impacts on clinical outcomes, utilization, and cost. And so the imperative is really there. And we need to have the proof points that if we address these things, that we can move the needle in the right direction, that we will reduce utilization, we will improve costs, that there is an ROI for this type of work.
Now, this is great research. And, one of the biggest issues that people have when they do these sort of analytics is what can we do that really has an impact? So it's a nice little story I think you have around your work with PAPA Incorporated.
Absolutely. I mean, it's a great question. Okay, so how do you tackle loneliness, right? How do you tackle how someone feels? And what we found is you either need to bring someone out of their house and take them to a community center or something like that, or you need to bring a resource to them. And so we've partnered with an organization called PAPA, and essentially what it does is it connects college kids, they become the PAPA Pals, to seniors, and it's a non-clinical intervention. So it's not about any kind of clinical intervention, but it's really, they spend time with them. They watch a movie, they do light household chores, they help go pick up their prescriptions, just basic things like that. And so we did an early sort of minimally viable product study with them, and we found that just doing this for 10 hours a month over 4 months statistically significantly reduced loneliness scores using the validated UCLA loneliness scale. It significantly reduced unhealthy days for us, both mentally and physically unhealthy days. And so that was really, really positive. The participants didn't want to give up their PAL when the intervention was over. They loved it so much. And, not to put too fine a point on this, everything that we do is about improving the health of our members, of our patients, but there needs to be a business case. There's the no margin, no mission, kind of mentality around this. And what we found is that participating in interventions like this also increases our net promoter scores. It increases membership growth and retention. And so there's a value add there outside of the clinical benefit that members really, these types of interventions resonate with them, and they're more likely to stay with us and stay longer and give us more and more opportunities to impact their health.
No, that makes a lot of sense. And this is what's so impressive, David, is that you see this sort of impact across the board, depending, it doesn't matter what community you're in, right? There is an
That's
impact.
right. That's right. And during this exact time period, the board visited San Antonio, New Orleans, and Tampa Bay in person to actually talk to the folks on the ground who were responsible for the community connections, like prescriptions for healthy food, like the senior centers, all of those activities. It's a very impressive operation when you see it face to face. But let's remember, the economic incentives are aligned from the payer perspective.
So this is so critical, is how do we get the economic incentives aligned, and will payers, providers, and community agencies be able to collaborate in the way that you've outlined, such as with PAPA Inc.?
Well, yeah, and I'm excited about the emergence of payer-provider partnerships. I think this is a really important early trend. And if you don't own the payer, that's fine, but I see a much brighter future for all kinds of joint ventures, all kinds of partnerships between providers and payers, because at the clinician level, we recognize that these partnerships are what really will change behavior.
Yeah, and I can say that, and David, thanks for being on our advisory board here at Innovaccer. The work we've done with Humana is being able to exchange real-time information and data and analytics results between the payer and provider in their workflow, and that starts to build the trust if the incentives are aligned. So
yeah, and I think this graphic is really important. I hope folks are paying attention, because to actually have some real evidence about lowering costs while going upstream to shut that faucet, that's exactly the take-home message from today.
So let's take a view of our audience and see if they think this type of collaboration is actually possible. So quick poll, do you see payers and providers and community agencies collaborating as part of their strategy, their clinical strategy, their population health strategy? And you may be in the boat that you never see payers and providers actually realistically collaborating, or they may have their own different incentives in doing things separately. It's been a history of that. They each may feel it's the other person's responsibility, the other groups, or there may be increasing recognition that collaboration is essential. So let's see how much trust that people have with where this is going. But I think in the meantime, you know, I'm curious on the payer side at Humana, Andrew, what's made the difference in the thinking? Like it's a culture change, right? To think about this sort of collaboration. What are the key essential ingredients in creating that culture change around collaboration?
Well, we have to recognize that we can't do it alone. We have to recognize that every stakeholder in this complex healthcare ecosystem has unique assets, and that we need to leverage them all if we're going to improve the health of individuals and populations. And you're absolutely right, it begins with trust. And trust often begins with sharing data. We have to be transparent. We have to create that interoperability where we're sharing data so that we all have the same information. I think that's really foundational to what we do. Then we have to partner together on interventions. Different organizations have different types of assets, like I said. So physicians have direct access to patients, and they have that trust factor with the patients. Often insurance organizations do not have that trust with the individual. And so going through a physician, you're more likely to get buy-in on an intervention. Just one thing to do. Insurance companies, on the other hand, have tremendous assets. We have disease management programs. We have technology platforms that we can deploy. And so every person, every organization in the ecosystem has unique skills and assets to bring to the table, and we have to leverage them if we're going to achieve an outcome that we all want.
So David, when you're training residents and health professionals who come in for executive programs at the university at Jefferson, how do you start to teach people, or what are some of the issues that you use to help people get over this barrier of thinking in this non-traditional way about social determinants of health?
Yeah, great question. So just last week we had our Population Health Academy. That's a great example of, to answer your question, we bring together 35 leaders from around the country for a 1-week boot camp in population health management, and they learn from one another. As Andrew alluded to, we have that program 3 times a year. We bring together people annually at our Population Health Colloquium with folks from really all over the world. We have the Hearst Health Prize. Last year we had 150 submissions of programs all around the country that are doing exactly what's on this slide, coming up with these kinds of payer-provider collaborations, among other issues. So we like to think that we're the platform, we're the neutral territory to provide the opportunity to bring these groups together, to study what they're doing, to disseminate the results. As Andrew alluded to, some of the key publications are in our journal, Population Health Management. So I see our college at the center of the conversation. And in God we trust. Everybody else bring their data.
Absolutely. And speaking of data, let's go ahead and bring up what our audience has responded here to this question. I'm curious about the trust issue.
Well, check that out. Wow,
Yeah.
it's pretty exciting. So increasing recognition that collaboration is essential. Well, outstanding. So I think we're witnessing the birth of a trend right on this webinar. So anybody who's participating could say they were present at the, initial recognition.
Awesome. Okay. Well, this is great. So, one of the things, Andrew, that we've referred to is how Medicare Advantage as a product, if you will, from CMS has really allowed us to align the incentives a little bit more between payers and providers to collaborate. Can you speak to this?
Sure. Well, a couple of different ways to approach that. One, I think, value-based care is obviously really important in all of the models that Dr. Nash mentioned earlier. But the other thing that's been increasingly important to us is the idea of trying to address supplemental social determinants of health within supplemental benefits. And up until really this year, that wasn't possible. So just a quick example, food was not considered related to health or health outcomes. And so we couldn't cover food as a supplemental benefit. Now, just recently, just this year, CMMI has come out with some newer models, value-based insurance design, or VBID, and SSBCI, which allows us to address social determinants within chronic conditions. And so allowing us the latitude to begin experimenting with addressing social determinants either directly or in concert with chronic conditions, and doing that through benefit design has been a really, really great opportunity. And I know we and others are looking to begin experimenting in that space. And as we get more success and proof points, we'll, hopefully expand in that space as well. But I think that's just very exciting and something we haven't been able to do before, and we're really excited to get started on it.
So David, you've worked across payers and providers and the whole ecosystem, policymakers on the Hill. This concept of changing benefit designs to allow these alliances with social agencies, where do you see, now that we have this birth of collaboration witnessed on this webinar, where do you see this heading?
Well, I'm excited about the initial forays here for sure. I would make two observations. One, pretty great that even in a Republican administration, we're seeing positive experimentation to expand Medicare Advantage and to pay, as Dr. Renda noted, to pay for some of the social determinants. So in a nutshell, expanding the great attributes embedded in Medicare Advantage definitely puts us in the right direction, along with what we've already talked about, CPC Plus, oncology care model, and all the rest. I think what I would say is, instead of Medicare for all, which we could spend a day discussing the limitations of that, the real answer is Medicare Advantage for the appropriate population. If you expand Medicare Advantage, that is the proven program that we know works. That's the take home from this slide.
Yeah. And I think, as we brought up before, and Andrew, you've detailed that with some of your choices, is you need really good evidence around a good assessment tool to address these issues, a good intervention, and good collaboration and partnerships with community agencies. And how do you forge that? One of the questions that comes up is, we're in this also age of emerging next generation technology, right? We have big data, artificial intelligence, machine learning. And as we use these new techniques, where do you see the impact of technology having on our ability to really tackle these issues around identification, partnerships and interventions and collaboration?
Well, I don't think nothing that we've discussed in the last 45 minutes is possible without the technology to track physician practice decision making, without the ability to close the feedback loop. Let me put it more positively. We need the technology to make any aspect of what we've been talking about work, including risk stratification, including tracking the impact of the healthy days. Without the technology platform, we wouldn't have any of the evidence. So I think this is the confluence. It's a great time to take a step back for a moment and say, wow, we've got all the tools now. Can we apply them and use them in the right direction?
I think that's 100% true. And I think about this two different ways. I think, number one, we need the platforms and the infrastructure that allow for the standardization of screening and referral, right? So we need the basic, whether it's EMR systems and things like that, so that we can do that in a standardized way. The other thing that we need are the advanced analytics around social determinants. So again, treating it like we do chronic conditions right now. We need, to apply AI and machine learning and predictive modeling and natural language processing and all these kind of new advanced analytics that we have, we need to put that against social determinants. We need to elevate insights, and we need to elevate them at the point of care. And so if we can do those two things, develop the platforms needed to standardize things and integrate the advanced analytics to really identify the insights when they're most needed, then I think we win.
No, that makes a lot of sense. And, you know, one of the questions that people have, because everybody's busy, physicians are busy with their EMRs, which is consuming their time. Care managers are busy, you know, with their care management platforms, trying to figure out who to call with a telephone. You know, one of the big questions is what's the impact on workflow, right? And how do people make the shift with these new technologies? So, you know, we've done a lot of work at Innovaccer here in trying to present information and insights into the workflow, and I think that's been very helpful. I know at Humana, you've done also similar things around looking at kind of how do you bring social vulnerability data down to the level of a zip code or a census tract. How has that been helpful for helping your collaboration with community agencies and identifying patient level risk?
Yeah, I mean, it's been, again, absolutely critical. Data is so important here. And just as you see this heat map here, certain social risks are regional, and that's important to understand. But it's also it's also really important to get as granular as possible. So getting down beyond county level to census tract, for example, is really, really important. So what we've done is we've developed a tool called Zoom In that takes over 100 different external publicly available sources from everything from census data to CDC 500 cities data to Robert Wood Johnson, and puts it into a social determinant heat mapping data visualization tool. And so for that, we can plug in an address and map different social risks and understand exactly what's happening around a clinic or around a patient, and figure out how to intervene. We've also integrated a community resource directory, so it becomes not just a diagnostic tool, but also a treatment tool. So as you've identified those risks, you can immediately connect a patient to a resource, and hopefully they get there and get the result that we all want. So I think data is absolutely critical. And like I said, you can take a macro view and understand, you know, where a population is. You also have to take the micro view and understand how an individual or a clinic or a physician is impacted by these different social risks.
Well, this has all been fascinating, and I think we've had a great discussion around some of the work that Humana is leading here, some of the teachings that are coming out of Jefferson, and how this is impacting the world. And as witnessed here, the world seems to be embracing this issue. We're looking at how social determinants assessment and interventions are a new frontier for population health management. David, where do you see the future of this going? Do you think we're going to actually bend the curve, bend the cost curve? Do you think we'll start to see better outcomes in America like we see in other countries?
Boy, David, Nace, you know, Will Rogers said there's no future in predicting the future. So here you go. I sure hope that we're on the right track. We've bet the mortgage, if you would, that no outcome, no income is the future, that going upstream and shutting off the faucet rather than mopping up the floor is the future. And we're trying our hardest to, excuse me, translate that into graduate level training in our journal, in our annual meeting. And our job is to, you know, spread the gospel and to continue to proselytize, if you would, that this is how we see the future unfolding. It's just great to have people like Andy from Humana kind of giving us the on the ground view and with the real data in various communities that prove that when you go upstream, you could actually improve outcomes and achieve savings. And we got to align the incentives. So what I took away from today is very exciting to me about how many people believe in the payer-provider partnerships.
Absolutely. Let's go ahead and take some of the questions from the audience. So here's a question for Andrew. When we go back to looking at the data you had from different regions, one of the questions was, why did unhealthy days increase in Louisville, Kentucky and Broward County? Do you have insight?
Yeah, it's a It's a really good question. I mean, you know, we don't see uniform improvements across all the communities that we intervene in. Some of those, like San Antonio, that was our original community, so we've been in there longer. We've developed really strong community partnerships, and there's some work that was already happening with the mayor's office and the health department. So there's a lot of reasons why San Antonio was doing so well. With Louisville in particular, one of the big issues there is behavioral health. You know, we made some progress on physically unhealthy days. So doing a good job of addressing chronic conditions and some of the underlying social determinants. But what we found is it was the mentally unhealthy days that was driving that overall trend. And when we dug a little bit deeper into that, a lot of it came down to behavioral health. So it can start with things like loneliness and social isolation, but we also have a lot of depression, anxiety. Louisville in particular is very high in suicide rates. So when compared to 50 peer cities, Louisville ranks 5th, I believe, in suicide rate. And so, you know, we haven't made as much progress there for those reasons. And I think it's something where it took us a little while to figure out those insights about where we need to focus. And now we need to pivot a little bit and really focus on behavioral health and mentally unhealthy days in general. So I guess just to conclude, I think it's not a one size fits all. The same strategy doesn't work in every community that we go in. Every community is unique. And that's, again, why it's so critical that we have boots on the ground and that we engage with community stakeholders, all those for-profits, nonprofits, faith-based, et cetera. We have to meet with them and really understand fundamentally what's driving health or preventing health in an individual community. And we have to reassess constantly. And so we need to know if we need to, you know, adapt and pivot our strategy.
You know, David, I was thinking in the nearly quarter of a century that you and I've known each other.
Yep.
You know, this issue of behavioral health continues to be an unresolved issue.
Yes, terrible. Here in Philadelphia in particular, ground zero for inadequate mental health services. And since so many people show up to their primary care doctor with psychosocial issues, most experts agree it's somewhere between 1/4 and 1/3 of all primary care visits. So we've got to do a much better job on this in particular. And those diseases of despair, depression is at the top of the list.
Absolutely. And, you know, another question from our audience, Andrew, was based on the slides we showed is, does Humana focus only on loneliness and food insecurity? Or are those the only two, or are there other SDOH, social determinant of health issues that you're also contemplating or looking at?
Yeah, that's a great question. I mean, I sort of described how we went from understanding there were 60 plus social determinants and we can't boil the ocean to doing those analyses that led us to focusing on those initial two. And we did that because they have the biggest impact on health-related quality of life. But that's only the beginning. So we're already expanding into transportation, housing stability are probably the next two in our horizon, but also recognizing that sometimes it's best not just to focus on a single social determinant, but we need to be doing comprehensive social risk screening. And so using comprehensive screeners like the Prepare screener or the Accountable Health Communities has their own screener that CMS has adopted, and really going through those, you know, top 7 or 8 domains and understanding what is that unique issue or the top issue that an individual has and addressing that. So I think using things like health navigators and comprehensive screening is really where we need to be, because everyone is unique and we need to understand, you know, what's the next best step for an individual.
So it does sound like we're just in that, or as you used to say, David, the boat moving away from the dock. We're at the very early stages of understanding all of this and making some progress, which is exciting. We are at the end of our webinar. I do want to thank a number of people and also make an announcement. So we had over 900 attendees today. Most of them stayed until the last minute. I'm very excited to hear that. Thank you all for joining. I would like to mention that we are having another webinar on the 27th of August. And this will also be on a different perspective of social determinants of health, particularly around engaging the community. And we're very excited. We will send you all an announcement about that webinar. Dr. Nash, Dr. Renda, thank you very much. You did a fabulous job. My applause to you. Great learnings to share with this audience. And we're going to continue to move ahead with improving the health of our communities. Thank you very much.
Thanks for the opportunity. Bye-bye now.
All right.
Thanks for having us.
Take care. Bye.